I think you. Yeah, my webinar is about to start. Thank you. Okay.
Can you hear us, Corin? I can, yes. Your mute was on, but now it's off.
Can Malikah hear us?
Dr.
Yes.
Malikah? Yes.
And thank you.
Okay, listen, oh, you're gone again. Oh, there you are. Gee, where are you,
Yes.
Malikah?
I've
Where are
decided to do this from my garden.
Oh, wow. Okay, well,
No, actually, an avatar is a good idea.
yeah. Well, ladies and gentlemen, good afternoon from Cape Town, and a warm welcome from a chilly night, a chilly day. Well, it's almost night over here because it's about to start raining, and it gives me
Load
great
shedding,
pleasure.
so it's night, yeah.
No load shedding. Yeah, we don't have load shedders over here. We're next to the Russians. So this is the good place to be. If you're near Russians, no load shedding. Promise you. So this afternoon, ladies and gentlemen, it gives me great pleasure, and I'm going to be introducing our speaker with the company of Professor Steve Jeffrey of Dr. Malikah van der Schyff. She's a person that needs no introduction, but nevertheless will get one from me. Just before I give her the introduction, now, Malikah, you're sitting in your garden. I must get the name of your gardener, because it seems like the gardener is, certainly has green fingers. So
Yeah,
this talk this afternoon is practical implementations of Tdap in maternal care. And next week we have Dr. Elna Rudolph, and she's talking on sex and the menopause, which brings me down to the next topic, not sex, but menopause. Malikah is are you the chairman of the South African Menopause Society, Malikah?
Yes, the president of SAMS, yes.
So you're the president of SAMS and also the president of the South African Menopause Society. Was that the same thing?
Yeah.
I also know that
Tdap.
you have a close association of the Medical Association, or nowadays called the South African Medical Association, or SAMA. And of course, you're also a committee member of SASO. You have been on many committees, including the committee at Mowbray Hospital, and you a health activist, community health activist. Now, just before we start this afternoon, just to say that for those that are a bit delayed, we've got the netball, international netball happening outside over here. So you may have slightly, well, there's actually a street party right outside this hospital, and the street party for netball. Steve, yes, Steve, do you play netball, Steve?
Yes,
we do.
Good, yeah.
No,
You got pop in at the street party.
Yeah,
no, I'm more of a
shooter. I'm the
pinball man
shooter.
than netball, pinball. Anyway, so there we go. Malikah has been with us for the past few minutes, and she's then, Lawrence de Blanche. Oh, we also have SANOFI people, and a great big thank you to SANOFI. We're going to end then with the SANOFI video, but we're going to start then with Malikah van der Schyff. Without further waste of time, Malikah, a practical implementation of Tdap in maternal care. And a thank you to Karen, the Pelvic Floor Foundation of South Africa, and a special thank you to SANOFI, and of course, the greatest thank you to Malikah van der Schyff. Thank you very much indeed.
Thank you for that. And thank you for that kind introduction. Appreciate it. And to SANOFI for the opportunity to speak. These are my disclosures. I have no conflicts of interest except to say this is a talk that is sponsored by SANOFI, and I have been part of their International Speaker Academy and part of their global pertussis initiatives as well. And the standard disclaimer that usually goes about the views expressed are mine. And my disclaimer, my own disclaimer, is that I'm not a vaccinologist, and the views expressed are not by the most key opinion leader on the subject. However, I am keen to facilitate CME, and this is my work, so I haven't had a friendly relationship with ChatGPT to make up this talk. The objectives of this talk is basically that
Hear us,
I was
Malikah?
asked, Christoph?
Do you mind if we chip in with questions as they come
Go
up
for it.
to keep it? Okay.
You're welcome. Yeah.
ChatGPT. What is ChatGPT, Steve?
Well, it'll make a talk for you if you want. So,
Is it?
yeah, you can just type in the subject that they're giving you, and actually gives you quite a
It'll
good.
do the work for you.
Most of my talks now are done by ChatGPT.
Is this
So,
sort of
yeah,
AI
So it's
like?
actually quite nice to see the one that's made fresh from someone who's not ChatGPT.
From
Okay,
a
this-
real human.
That's
Yeah.
the wonderful thing to have a non-ChatGPT talk.
This is a
You should
ChatGPT.
try it next time for your next talk.
Oh, I'll try that next time, Steve,
Yeah,
if
we'll-
someone asks me. Yeah.
We'll check on you.
Okay. Thanks very much,
And
Malikah.
the
Now we
difference with ChatGPT GPT is that the artificial intelligence is not going to be sitting in between you and your patient to try and implement your whether or not she's going to take her vaccine. So the objective for today is to try and speak about the scientific evidence behind supporting maternal immunizations and vaccines, its safety, recommendations, which is the standard, but I'm not going to concentrate on that very much. I want to talk about the barriers to implementation and talk about trying to keep it concise and practical for when you are actually sitting across from your patient and trying to assist them. So the outline, the initial to the introduction and maternal immunizations burden and the global and local implementations, not implications, and recommendations, that I'm going to be quite quick with because I want to concentrate on discussing what is practical. And you're going to see the slide popping up often about what is practical and how is it going to affect you when you're sitting in your office and talking to your patient. So I'm going to, and I apologize if you find that I'm going to go through the first few slides a bit too quickly, but I want to get to the kind of meat and the crux of the matter. So if we talk about vaccines and you're sitting in front of your patient, and I'm sorry if you're going to think this is going to sound like I'm insulting people's intelligence, but you have to actually be able to tell your patient what a vaccine is, even although it seems common knowledge that people should. So we know a vaccine trains the body's immune system to fight a disease that it hasn't come into contact with before. And we know that this adaptive immune response against the disease-causing pathogen, whether it's a virus or bacteria, is mediated by B cells that produce antibodies, which is your humoral response, and T cells, which is your cellular response. And the duration of the immunity is often dependent on the vaccine. And if we think practically with pertussis, you need to be vaccinated in each pregnancy. And some vaccines may just require boosters, and you will find that in the different combination or compilation of your Tdap vaccine. And we know that the antibodies we have, and the antibodies then prevent or reduce infections by recognizing specific molecular structures on the pathogen known as antigens, and they bind to the antigen, and on binding there, the antibodies will either tag the pathogen for attack by other parts of the immune system or neutralize it completely or directly. So we know that vaccines provide a protection over the lifetime, and we know that a lot of airtime is given to infant and childhood immunizations, but we are beginning to try and push more for maternal vaccination and immunization. And when you are talking to your patient, when you are going to get your vaccine hesitant or your anti-vaxxers, we know that vaccines have had a positive impact on public health. We know that it has decreased the numbers significantly of diseases. And one of the myths out there with regard to pertussis, for example, where you can see here there was a decrease, is that some of the myths are that people believe that it's been eradicated completely. And we know the effectiveness, and I'll talk to the slide later again. This was proven in countries like the UK who implemented their maternal immunization program. Patients will often sit in front of you and tell you that they are very scared about harming the pregnancy. And we know that certain exposures or pathogens or disease can have an impact depending on where in the pregnancy the patient is afflicted or affected. We know if it's pre-implantation, you're probably going to land up with a miscarriage. We know that if it's in the embryonic period, there might be major defects and altered functions of the organs that you might pick up on your level 3 scans later on. And in the fetal period, you know that you're going to get the complications that's going to be your problem when you are busy trying to deliver or trying to prevent that preterm labor, when you might have your small for gestational age babies, your fetal demises, your growth restrictions, or the malformations that are now pitching up. So the importance of maternal immunization, a mother's always going to try and protect her child. And we know that to protect the pregnant woman from infections that are potentially severe for herself and the unborn child, that's why vaccinations are important. And this would be potentially for influenza, because she can get as ill, tetanus, and our friend COVID-19. But the important thing is also to protect the baby via the mother. And this is where pertussis comes in, because you want passive immunity via the transfer of vaccine-specific antibodies via the placenta, and importantly via the breast milk, to protect the baby in the first few months of life before the active vaccinations that the child would undertake. And ideally, you want a vaccine where the maternal antibody concentrations would provide a level of protection and immunity throughout the pregnancy, but you also want this to carry on to get to the neonate and to provide immunity until it has had its primary series of infant immunizations. And this is, as I said, where pertussis becomes very important. And we know that the vaccination can result in the transfer of maternal antibodies across the placenta to affect the fetus. And we know that we can also get mucosal immunity by breastfeeding, because secretory IgA antibodies do get into the colostrum or the breast milk and is often there for several weeks postpartum. And we know that there's lots of information out there. This one is from ACOG, which does, list all of the safeties and the needs for maternal immunization. So what are the implications of harm? And I'm just going to concentrate on pertussis. We know that influenza, COVID-19, neonatal tetanus is there, but the idea behind pertussis is that your child is too young to be vaccinated successfully and fully, and is at increased risk of severe pertussis infection, even death. And as we know, while mothers may have pre-existing immunity to these infections, in most cases, antibody concentrations are insufficient to provide passive protection to their child, and they would need to be boosted with a single dose of vaccine. And where pertussis, practically this comes in, is that we need to actually boost in each pregnancy. So Bordetella pertussis, or whooping cough, highly contagious, afflicts babies quite badly, and is one of the top 10 leading causes of childhood mortality from any individual pathogen. And there are often many pertussis-associated complications, worst of which being death, obviously. And we know that high rates of immunity, up to 80 or 90% against pertussis, does not happen until the third dose of vaccine of the primary series, and that would be 6, 10, and 14 weeks. And these infants who are afflicted and they are younger and less than 3 months old would often require pediatric ICU care. And this is shown in the evidence that when the effectiveness of pertussis vaccination in trying to prevent those hospitalizations, I particularly like the last one, which is prevention of death, which is 95%. That if you ever wanted to convince a mother trying to say to prevent your child from dying, that should definitely get the message across as well. And, it tries to prevent the hospitalizations. You can see here it's within the 90s where that effectiveness is concerned. And if we look at death and the protection of pertussis against that, you can see in different countries it does show that as well.
So Malikah, Malikah. So we had a great talk by a neonatologist from from Joburg last few months ago, and
about the impact and the burden
pertussis. And interestingly, it seems to be like the one that one does really need to think about. I mean, but I just get the feeling that there isn't really an uptake of the pertussis in the community, or amongst gynecologists really, in terms of vaccinating their patients. Do you routinely to your patients, or how do you see it's actually?
I do.
Holding. Okay. And your colleagues?
I do routinely. I do know quite a few of my colleagues who do, but I think that we are actually in the minority, which is why a talk like this is quite, important. And, I'll talk about it later on, that the healthcare provider is the number one agent in convincing a vaccine hesitant mom to actually take the vaccine. But as we know, in Cape Town, a lot more gets spread by word of mouth than Dr. Google or even doctor herself. So a lot of patients will actually come to you and go, my friend's gynae recommended it. So hopefully by naming and shaming and saying my friend's gynae recommended it, why haven't you, or are you, or what, then you can have this information at your fingertips as well. And where it becomes really evident, Stephen, is when you look at the South African evidence, that we know that it's important, and protecting the patient against pertussis is important in the infant and the moms, especially in our HIV positive patients as well. If you look at the Western Cape here, We know that we had a very sharp increase in 2022. And you'll notice there that there was a dip over there in the pandemic lockdown years. And we feel that this decrease was probably because of non-pharmaceutical interventions. And then for a short while, as everybody was kind of vaccine fatigued, I think, and then ended up not taking it. We've had quite a lot of cases in 2022, which has resulted in some changes in our healthcare system, in the antenatal clinics and that, and I'll discuss that later on. But then as you can see that we have had, and the very embarrassing and sad thing is that the Western Cape actually led the pack here. And I'm not sure if we led the pack because we were notifying more or because we were just a little more negligent in pertussis vaccination in pregnancy. And we know that
in general, sometimes it opened the whole anti-vaccine discussion as well, and people who might not really have cared before now suddenly are vaccine.
I mean, did you guys see this? There were stickers. I actually drove behind somebody who had a sticker that said proudly anti-vaxxer.
Yeah, I've seen that.
And yes.
It's important to bump the car when you see that because
No. I was going to go there, but unfortunately, I needed to pay my medical insurance, not my car insurance. So I figured I'd rather just leave the car alone. So yeah.
Okay.
So we know that there is an increase in pertussis antibodies in both the mom and the infant, and this is important as well. So what is the practical message from this? Pertussis is a killer. Protection is proven. We know that there are national recommendations. We know that, there are societies like your SASOGs, your ACOGs, that are your RCOGs that would recommend it. And we know that these recommendations are in many different countries, including ours, which is not depicted here, but those that were actually implemented as well. And we know if we talk about implementing a national program, if you look at the UK, there was a major increase in pertussis reports in 2012, and they had a kind of emergency program introduced for pregnant women. They've eventually streamlined it and tried to change, to increase their uptake and increase the opportunities for women. And they did this with a lot of the ways that I'm going to be discussing as well. They had an ordering system, local vaccination centers, GPs and midwives were educated as well. There was lots of advertising going on, and they looked at their data as well. And they found that they had a massive drop in the cases of pertussis and protecting infants, and their vaccine effectiveness was shown, as can be seen in this graph. And of course, national programs in other countries as well. So if you look at Italy, there was where there was a vaccine uptake, we found that it was actually better for pertussis than it was for influenza. But that's probably for another talk, because I think influenza is a different evil and beast. And I think that most people think that the flu's not so bad. The flu's not going to kill me. I make a pre-COVID statement. The flu's not going to kill me or my baby. But the patients do understand, if correctly educated, the implications of not protecting their child against pertussis, which is why in countries like this national program in Italy, there was such a vast uptake over 2 years. So what is the practicality of that? National programs are effective. What are the guidelines where that's concerned for vaccination in pregnancy? If we look at it practically, and in South Africa, maternal immunization, there's certainly education about it everywhere. You'll find some of these on antenatal clinics. These you can put in your waiting areas as well. If you go and you Google it, we know that our national Obs and Gynae Society, SASOG, does recommend it as well. It's one of the first things that pops up when you search Tdap vaccination in pregnancy, South Africa. We know that it is, and for those of you who are SASOG members and access the app, which is quite excellent, you'll find your recommendation for vaccinations there as well, in case you forget. And I've put on the right-hand side there where you would find it under the Better Obs programs. We know that it's recommended. It is Tdap, so it is tetanus toxoid, reduced diphtheria toxoid, and acellular pertussis. We know that it can be Tdap, or Tdap, including inactivated poliovirus as well. We know that hopefully if ESCOM allows us well enough, it needs to be stored at 2 to 8 degrees and is given intramuscularly. And it is an inactivated, it has inactivated microorganisms, because those are the only ones that are able to be given, because live attenuated viruses are contraindicated in pregnancy, which is why our MMRs are not given in pregnancy. Third trimester, and I'll talk about timing again now, that the best time is in the third trimester, ideally between 27 and 36 weeks, for the optimal transfer of antibodies across the placenta to ensure maximal protection in those in that early infancy. And again, yes, every pregnancy. Yes, if she says to you, but my children are closely spaced, I'm still breastfeeding my first one. Nope, you still need it for your second one, even if you end up with 2 under 2, you know. And it was actually a South African that did the research that came up with the optimal timing and published it. And you know, there's some arguments about it, but we land up with early third trimester, and often would say in and around 30 to 32 weeks or 27 to 36 weeks, if you really want to throw it widely. Some have argued that it's better between 30 to 32 weeks because you want your more effective placental transfer in the later part, closer to birth. So you now have the knowledge at your fingertips. So now what are you going to do with it? We're going to talk about the strategies for the practical implications of maternal immunization. And the potential strategies to increase the uptake of vaccination in pregnancy will cover a range of stages. It's important that it is regulatory processes that have to be there, vaccine accessibility, the endorsement by us as the healthcare professionals, education on the benefits of the vaccine, and other multi-channel approaches to improve your uptake and decrease your barriers. So I'm going to go through them step by step. If we go through the first 2, we talk about regulatory processes and improving processes for the development, approval, and labeling of vaccines. And we can see how practically this could be done easily when we look at how the COVID-19 vaccines came out, and how initially your vaccinologists said, and your scientists were saying, oh my goodness, we're going to need 2 years and 2 years of research and everything. And, you know, 9 months later, we ended up with vaccines that was accessible to healthcare practitioners. So you also need your accessibility, convenient location of your clinics, free vaccination available at antenatal clinics. So how does that feature for us? And when you look at accessibility, we're actually talking about social determinants of health. We're talking about equity, universal healthcare coverage, your infrastructure, your evaluations of all of these social conditions. And how does this work out for South Africa? Right now, where accessibility and universal coverage is concerned, it's kind of hot off the press, but the pertussis vaccine, Tdap vaccine, will be available in antenatal clinics and accessible to all in the public sector from 2024. So
Malikah?
we know that it's
Malikah? Sorry, Gerard Turan has just asked that question. Is it available in the public sector? If not, when will you roll?
Not yet. So the Western Cape was hoping to have it, and I'll talk about the Western Cape a bit separately, because we had the outbreak. So there was talk about it being available from June or July, but to my knowledge, it is not as yet. But from Jan or Feb, depending on paperwork, implementation, everything, it should be available within the public sector from about the latest February 2024 in all provinces.
Okay, thank you.
Yeah. And, you know, so I think this is phenomenal. There's a lot of people, some of them on this webinar, who are part of the processes of pushing for this. And I'm supposed to stay unbiased, I know, but I know people like SANOFI actively went also and campaigned for this to happen as well. And I want to commend them for that, because it took a lot of work to get this in there. And I mean, we've proven with vaccinations like the flu vaccine, tetanus vaccine, and with COVID-19 vaccine that we can get things into the public sector. We must just, the need must be there. And so the FOMO thing is going to be, we in the private sector are going to be left behind. We've always had accessibility to the vaccine, but we are not recommending it to everyone. So recommendation is important. One of the important potential strategies to increase uptake is vaccine endorsement by your healthcare professional. Your healthcare professional recommending vaccination to pregnancy, enabling us through training, reimbursement, and management of workload to be able to do that. It often needs to be face-to-face, but let's not underestimate the internet and text messaging are important sources of information as well. So what is our role? We have been found, and sometimes I wonder if I believe this, the best ways to reach pregnant women has been proven to be the healthcare provider. That comes out in the literature all the time. And I know sometimes that doesn't feel like that when you're sitting in front of the patient who's telling you what their cousin or their aunt told them, or the car guard said he found on WhatsApp. So, but we do find that the healthcare professional is the one that is most trusted for the information, the internet, and then, of course, let's not forget your other gynaes, which is your family members. And this has come out in studies as well, where they looked at different barriers and barriers to uptake. And women were always worried about safety for their child. And women always felt that getting a healthcare provider to recommend it was one of the factors they most frequently reported being the reason for the increased uptake in vaccination. And this is shown in other surveys as well, and especially when we look at things with pertussis and influenza. Interesting thing, sometimes it feels like the Western Cape has the most anti-vaxxers, or South Africa or something like that. But if you look at it, even before COVID, Europe had the lowest rate of acceptance of vaccines, and again, doctors' recommendation had the most positive impact on acceptance. So what is the practical implications of this? The practical implications of this is that we need to improve the communication and the dialogue between the pregnant woman and their healthcare professional around vaccination. And there needs to be crucial outreach to mothers directly by their key or primary supporting healthcare professional. Whether that is us, whether that is the midwife, whether that is their general practitioner or well woman doctors, it is up to us as healthcare professionals. But you sit in this consultation, there are so many things. There's including questions of, can I have feta cheese if I'm going out to dinner tonight? But before we even get to, is the vaccine safe for me and my baby? Do I really need to worry about this? I mean, I had somebody I will never forget during the COVID, during the pandemic, who said, COVID doesn't really come to Nooituk. We're really careful and it's okay. And, then it hit everywhere like a wildfire. Are these diseases dangerous to me? I'm careful. So will I be safe? We did see a decrease during the pandemic, and many people say, but I work from home and I don't really go out. So am I really safe? We were talking about how with pertussis, you should cocoon and boost people around you or frequently in your space or in your life. And people think that includes, the grandparents and extended family. But, I'm really careful, so I'm probably going to be safe. But then, you take things from the Take-A-Lot guy, from Mr. Delivery, from Uber Eats, are you sure you can be safe? Can't I just get it after the baby is born,
Malikah, we've got a question over here on that very topic. Do you have to vaccinate the mother, but what about vaccinating when the baby arrives, the father stroke husband?
So often what I would, no, both of them go together usually at the time. And then afterwards, or close to birth, it would be Oma and Opas. And often I've often got a lot of patients who will say visiting grandparents would do that. And I even had somebody who refused her grandparents from her own parents from seeing the child until they got the vaccination in South Africa, because they live in the UK and it's not easily accessible to them. So they had to come here and actually access it. So I think you've got a perfect opportunity if you have the couple with you, and many of us will have both parents in the consultation, so you can write your scripts for both of them. But so that's what I would recommend, practically, to try and get that done. But definitely those who are around you, the cocooning has also been shown to be effective. But, and I haven't put any of those slides in, if you look at all of those, cocooning, the most effective way to protect the child is actually maternal immunization, but we shouldn't miss the opportunity to include them as well. So if we look at it, what is practical during the consultation? This I found quite helpful. We talk about saying that you should share information, share reasons for maternal immunization, highlight positive experiences, reinforce benefits, and strengthen confidences. And that's the way we actually address it. So you could say to your patient, yeah, I really wouldn't give your daughter the HPV vaccine. You know, she's going to be a good girl and she'll be safe. Or you can say, listen, I absolutely believe it's going to protect you against CA cervix. So there are ways that we address it, and we know how we look at queries and concerns. And patients look to us and our reactivity with how confidently we can say that. And you should remind them about patient protection, the protective effects of the vaccine, and we'll go through that, and explain the implications of the disease. So if you're trying to remember it, you can just remember it as share. And the idea is communicating efficiently, we know, is the key. And we know that we already have a trust relationship, but we're trying to build this trust relationship and trying to move forward to address doubts and concerns about vaccination. And so corrective information is found to be generally effective at reducing misperception, you know, especially, for example, like around misperception that the flu vaccine causes flu, you know, things like that. But what I love about this slide is it talks about setting positive messages rather than repeating myths. And that's interesting because we often want to kind of get into a rebuttal with a patient, or you get into an argument with them. So the idea is repeating myths when you're correcting people is actually not beneficial, and you're not going to win any battles there, you know, and repeating it is just making them remember it more, you know. So less is more, says me, who talks too much, and use simple responses when refuting any myth, you know, and confidently, so that the patient, you know, then that can help you with trying to prevent that hesitancy or alleviate her symptoms. So no matter what you say to some people gaan hulle kop in die sand druk and not listen. So what is our role in overcoming barriers to vaccination? We know that the perceived risks of vaccination remain barriers to its uptake. We know that it is misperception, misinterpretation of medical information, finding certain medical information difficult to understand, illusory beliefs or myths, and what impact the media might have on it. You just need one thing in the media, I'll talk about it later, and then, you know, you've lost your patient completely. And despite widespread recommendation, vaccination, you know, in pregnancy varies markedly in different countries. Look at this, look at the different countries. You know, I mean, Greece doesn't sound like they like vaccinations at all, or Poland. And some of the reasons for not recommending vaccination in pregnancy is fears about side effect or lack of experience. And this was when they spoke to obstetricians and midwives in Spain. Two of the main reasons was concerns over the potential side effect, and as I said, the lack of experience with it, you know. If we want to understand where vaccine hesitancy comes from, and I know I'm repeating things that we know, but it's from the lack of our recommendations, concerns over safety, lack of knowledge on the vaccine. And this is where I commend Stephen and Pete for actually having very comprehensively discussing the different aspects around maternal immunization, being unsure about the benefits of vaccination, what the not knowing the perceived risk of the disease or the disease severity. Nobody thinks the flu is terrible until they land up with pneumonia, or lack of trust in the vaccine as a whole. So again, common barriers, safety, misperception, no recommendations from us. That is important. That comes up often. From us, it's actually our lack of knowledge. And the thing that I know some of you are thinking in your mind, we just don't have enough time to go through this all the time. So what is the...
Can I,
yes?
at this point, bring up one of the questions, Steve?
Yeah.
Dr. Nell, there we go, Leon Nell. Can I just read what he said here? You can maybe comment.
Okay.
We cannot blame the public to be so vax hesitant. I'm reading it verbatim. Seeing the complete botched recent vax experiences. So this will not go down well. We as practitioners must produce absolute evidence that any procedure is truly safe and effective. Thank you.
Perfect. I couldn't have said it better. Thank you for that.
Thank you.
The interesting thing is that when the research is done, vaccine hesitancy is generally a problem that obviously affects vaccine uptake, but it is especially in the well-educated and the wealthy. So that we found as well, that the trust there. And a very good document that I've read is looking at around COVID-19, where UJ, their Human Science Research Council, did their survey and looked at vaccine inequity and hesitancy. And it was interesting to, to see what came out. This is just a summary of some of their key findings, and if you look at it, I know I'm talking about COVID-19 here, but the same ideas apply, that they found that the middle class or wealthier patients were much more hesitant, but understood the information more, and they even say here, television and radio remain the most dominant sources about COVID-19 vaccine. However, the unvaccinated are more likely to draw their knowledge more frequently from online news sources, social media, family, friends, and colleagues. So they looked at things like that. They looked at, for example, down here, they say white adults had the highest level of reported vaccine coverage and Black African adults had the lowest. Despite that, Black African adults are more favorable towards vaccination than white adults. So these were very interesting observations and that the research brought out. And they also had they had a few papers, and one of them was the previous one, and the other one was barriers to COVID-19 vaccine. So a lot of when we spoke about COVID-19, it was, where are the clinics? They didn't know where it was. They couldn't access it. Like people living in Free State and Gauteng reported more frequently that they didn't know where to go. Whereas people in Mpumalanga and Northern Cape reported more difficulty to get to where they knew they needed to go. So if we talk about that first point about accessibility, we know that our antenatal clinics, patients know where they are. So that's going to be excellent when we talk about uptake, but also our rooms, they know where we are, when they access us. And when we look at it and vaccine hesitancy, they talk about complacency, convenience, confidence. When we look at the, trying to look at the model of vaccine hesitancy and where it fits into the health system building blocks. So when you look at education, and we continue with education on the benefits of antenatal vaccine, improving the awareness of it amongst us and to the pregnant mom. So I know Venn diagrams, but if you look at it, education, information, and health system improvements will enhance your uptake. And we know that we talk about, a lot of the recommendations will say actually get to them in the first antenatal visit, but it may need to be, further into the pregnancy that you discuss it. There can be posters in the places that you go. You could distribute material at antenatal care facilities, do your staff education, and again, your health system improvement. Now, our health system is getting there. Maybe not this year, but next year. So we need to be there as well. So we need to improve public awareness around it. We need to understand the need for immunization, what efforts are in place. I will talk about what Western Cape government has done around that. And we know that campaigns can be catchy. You know, there were lots of campaigns around vaccination when COVID-19 was around as well. So again, if you think knowledge is expensive, try ignorance. If we look at it just, and I'm going back to COVID-19 rather than pertussis at the point, but, you know, Western Cape government had active programs looking at all of those different strategic focuses to try and aim at getting to your anti-vaxxers, to get beyond vaccine hesitancy, you know, and this is out there. So practically, we need education around the recommendations. If we talk about the recommendations, I've spoken about the timing. If we're talking about private, I might be out by a few rands and cents, but that's in and around the cost of your Tdap vaccine. Is it covered by your scheme? Question mark, yes. You know, most of them will suck things out of your savings. I know when we spoke about and when I questioned a lot of the drug companies and the schemes around it in our role as GMG also about why aren't you covering the vaccines? You know, it was, because it's not part of a national implementation. And so I think that we may see schemes changing and hopefully covering it more once this gets into the public sector a lot more. What about availability? We have Tdap, so tetanus, reduced diphtheria, acellular pertussis. We can have it as a Adacel Quattro, or Boostrix. So Adacel Quattro has the IPV in there as well, and that's the available ones in South Africa as well. Your patients are going to ask you about contraindications. What's the most major contraindications against a vaccine? Having had a severe allergic reaction to a previous vaccine. And I emphasize severe. Having a burning arm, feeling a bietjie papperig afterwards, those are not severe reactions. Can you mix and match? This Department of Health and the national, our CDC ended up recommending that you can mix and match. I was just losing the name of our CDC, NICD. The NICD has recommended that you can mix and match. They don't speak about pertussis here. They speak about COVID and flu vaccine. But if you were to take flu and COVID and pertussis, however, you're unlikely to mix them. Pertussis is going to have to be at a set time. And sometimes your flu vaccines are seasonal that you're giving them, and they need to be given earlier on in the pregnancy. So cost and medical schemes, those were the different vaccines, but your costs, as I said, the provision of vaccine funding for maternal immunization is highly impacted by demand, the presence of national recommendation and clinical decision-making. So we've always had the clinical decision-making. SASOG has recommended it, Department of Health, all of those. Presence of national recommendations are there, and it is now in the public sector. So we hopefully, I'm hopeful that perhaps this will mean that as the medical aids change, it will be covered. There needs to be the concentration on the improvement of the quality of vaccine-related and volume of vaccine-related information given. We want our official resources, government-endorsed campaigns, national society campaigns, and I'll go through these. The information is out there. It's on the web. We need to talk about protectiveness and the safety. We need to tailor the messages and campaigns so that it addresses a woman's needs and concerns, and her needs and concerns are often around protection. And again, there is examples of communication out there which proves that it provides protection and safety. There must be positive messages which, safely and respectfully dispel myths around that. We need to protect the public trust in safety and efficacy, which means positive messaging and knowing that it is safe. I mean, there are these pamphlets that you can hand out to your patients as well. Oh, sorry, you're not able to see it with my little avatar, but you can, even if you think I'm not able to talk about it at the first visit, there is promotional and educational material out there. Safety and tolerability.
Just go back
Yeah.
2 slides, please. Those
2
pamphlets.
slides there.
There.
Yeah.
Where do those come
Yeah.
from?
So those, I picked up mine at the Menopause Congress, actually, where SANOFI had a stand there, but your local, like that one particularly, is from SANOFI. I know
Yeah.
there are others as well, and I have a pad of paper like that. My little avatar's preventing me from showing my thingy, mine, but yeah, and then the Seki breaks it off and gives it to them as part of their little welcome pack, so
That looks
that's
like a very good one. That
done.
particular one that you're showing now.
Yes. Yes.
Yeah, that's a SANOFI one, is it?
Yeah.
Yes.
So you can
Maybe if I
see-
can add on, if you work within
Yes,
the
yes,
private
go for it.
sector, you can contact your SANOFI PSR, who will be able to assist you, or contact myself or any of the organizers. We'll be able to assist you with some material. And then, as Malikah mentioned, the vaccine will also be rolled out in the public sector towards the beginning of next year. And for that, Department of Health will support with us in the background for any material.
Okay, thank you very much.
So most of you now put your little reminders in to tell your Sekis to contact somebody with regard to that. So I'm going to quickly go through like how to assess vaccine safety and efficacy. We know from the COVID-19 vaccine processes that there is always an adverse outcome and reactions council group evaluation center that looks at the vaccine throughout its lifestyle. So the safety and efficacy of vaccines are tested rigorously before they are licensed for the population use, and long-term safety is monitored throughout the life cycle of the vaccine. We know that. Tolerability, just quickly, it is very well tolerated and not associated with any unexpected safety outcomes. There is no increased risk of stillbirths, maternal or neonatal death, and I'm going to leave that at that for the sake of time. So there are no serious vaccine-related adverse effects. So we know that young infants can develop severe pertussis. We know that the greatest impact on the prevention of pertussis is actually for your maternal immunization, and that we know, I've spoken about cocooning as well, and I just want to tell somebody who's trying to phone me that I'm unavailable, and that the optimal timing is in the second or early third trimester, and we know that it's well tolerated. But we have to explore the other side of the story as well and understand why certain countries are hesitant to vaccinate in their national campaigns. If we look at South Africa, it was cost. It was trying to convince people. COVID-19 has assisted very much with that, and active campaigns from national societies and key opinion leaders and even companies have helped where that's concerned. And we need to understand the media and debates online with regards to trust in maternal vaccination. So there's lots of misinformation. We know that there's a hell of a lot of fake news out there. If we look at, for example, myths about pertussis, it's been eradicated. My child is getting the vaccine. It only affects babies. So those are myths that are out there. And you guys know that there was a hell of a lot of scary stories about vaccines out there. My favorite COVID-19 one two of my favorite ones was that we were all supposed to die February 2023 after we got the vaccine, 2 years after we got the vaccine. The other one that I liked was that I was going to turn into Magneto because of the magnetism story, but that never happened. So even if myths are busted, it gets done in such a way that medical, our validation is like on page 5 or 6, and what things things that go wrong is on page 1. If you just look at the whole debate about mercury in vaccine causing autism, the same person who made the allegation retracted it, but that didn't get as much airtime, as the others did. The other thing is, do not forget to exclude the importance of your community and family involvement in education. You guys know everyone is your gynae. There's little me over there in the corner, and there's everyone else that's the gynae that's going to give people information. So we should harness that and empower women. And as we spoke about in the beginning, guys, word of mouth often, for example, in Cape Town, word of mouth is much more important than other advertising. So what is the practical implications here? I want to talk quickly about the Mowbray maternity experience, which I think is a great way of doing things. And I really can't speak other than Mowbray maternity, where I'm chair of their health facilities board. So I know about this. I don't know about other parts of the country or anywhere else. What have they done? They have group antenatal care and education. So patients might be seen individually, but they're counseled in a group. Patients provide support and assistance to each other, and their appointments are booked together. They are supervised by a midwife, and they would assist each other with certain observations and testing of urines and things. All the counseling is done in the group setting, and no opportunity is missed to counsel, and they commence their counseling on vaccination in the first antenatal visit. So that's a good idea if you're trying to figure out how are we going to implement things, and how are we going to successfully implement Tdap being into the antenatal process. And what was their experience during the pertussis outbreak? Vaccines were procured from the hospital budget, and our health facilities board sometimes assists with trying to improve their budgets. But the hospital budget during a pertussis outbreak in the Western Cape, they procured it. And it was initially meant to cocoon the high-risk staff. And you know what we found? The staff uptake was very poor, but the patient uptake was excellent. I was chatting to the nursing managers, and they said the patient uptake and interest was just like practically 100%. So that is good news for trying to look at that. What does that mean? That means hopefully we can change people and have them stop becoming vaccine experts, because we'll be educating them. And if we quickly, as a last thing, just look at the multi-channel approaches, looking at different agencies to bring out awareness, not just, I've shown you Western Cape government can do it. That there's always the internet with Midwife Wiki and Dr. Google. There are lots of resources out there for you as well. And this is a fabulous one. And this one you can get free on the internet, which is from Gloam, which is the continuous textbook of women medicine series. It is hot off the press, as in 2 or 3 weeks ago. And, the maternal immunization. And, I've taken some of my pointers from the role of maternal healthcare providers here, which I spoke about earlier. And they also talk about their practical recommendations around the challenges that is found in low and middle income countries versus high countries. There are other agencies that talk about it. There's Huggies, there's Diskim, there's so many different, information out there that people can find. We just need to secure it. During COVID-19, even your medical aides was talking about how important vaccines are. The NICD, if you just Google it, I've mentioned that before. These are the resources that we have available to us as well. You've got international, continental, South African, and local as LACA. Our guidelines and our recommendations. So practically, the common barriers to vaccination is safety concerns and lack of information. We are responsible for helping with that, because healthcare provider recommendation is the most common predictor of vaccination in pregnancy. We recommend that it happens from the first visit. We believe in improving patient awareness, and we believe all of these strategies that I've mentioned can actually help. But it is multi-layered. So I thank you for your time and for listening, and I hope that made it practical enough.
Thank you very much, Malikah. That was excellent, and we really enjoyed it, and we love your passion for this whole issue of vaccination. We do have two very interesting comments, varying. The first one was just read a comment from KZN Port Shepstone, anonymous attendee. For all my patients, Tdap vaccine at 28 weeks. Doesn't take long to discuss. Majority of patients are happy to take it, especially when they hear that it can prevent the potential death of their child. And even those who have not received COVID vaccine are okay with it, as is not a new vaccine and they trust it.
So they can trust. That's a good thing. Thank you for that. I appreciate that. Yeah.
But then, I think this next comment really does summarize in a way still this sort of undercurrent of anti-vaxxing, where they say, this person says, thank you for the presentation. Studies and reviews have associated DTP with high mortality in vaccinated girls versus unvaccinated. So does the benefits really outweigh the risks, and have any more recent studies made any conclusion to the contrary? So there's just, although, you've really highlighted the safety of these vaccines, but where do these people get this hesitancy? I mean, is there anything in it, or are we just brushing it under the carpet? What's the real essence of what they're saying here? Why would people do that? I mean, what do we tell these people who are vehemently anti-vaccine to the point of placing themselves at risk for some of the COVID stuff, and then obviously placing the kids at risk? And what do we, where do they get this from?
COVID-19 created a global anxiety disorder pregnancy is one of the most unpredictable states. And for many of your patients who are very anxious, they believe that their knowledge is power. And there are going to be people that we are not going to convince. And it often, I believe in cases like this, it would be to reiterate the points and the science at every visit, but not just with the mom concerned. I'm lucky that a lot of times, people come with a posse. It's the Oma and the mother-in-law and everyone else. And I think that the whole point about trying to get the community and everyone else around you, to figure out where they get that information, try and dispel it. I think that's very important. I don't know about any other studies further to what you're talking about. I haven't come across that. I don't know if Fatima's shaking her head there, if she wants to comment.
No, I was just going to say I would really be interested to see the data, because often sometimes it's a really small study where the results were inconclusive. Or sorry, can you hear me?
No,
we can.
Okay. I was saying I would actually like to encourage the inquirer again. I think our contact details, or you can contact us via the conference organizer, to actually share that study with us, because sometimes it's a really small, and we always say this, that often the anti-vaxxers are more vocal, and that data is spread more widely and more readily than where the evidence and science is. I think, Malikah, you presented a lot of the information behind it. I mean, CDC first recommended the vaccine for Tdap in pregnancy, while for us it might be a bit of a newer concept. I mean, it's going to be introduced next year. But like CDC first rolled it out in 2012, that was when they first used it for an outbreak in the States. ACOG, I think they put out their recommendation in 2017, WHO in 2014. So for us, it might be a new vaccine. I really want everybody to think about it as something where there's a lot of evidence, a lot of safety data to show that the vaccine is well tolerated, both for mom and for baby.
Okay, thanks very much. I think you're absolutely right, spot on the money. And we've heard all our questions from our attendees. There's been many hundreds of them, and I'd like to thank
you for being interactive.
And thank you for that wonderful talk that you gave, Malikah. And a special thank you then for our sponsors. And also just a reminder that next week we have Dr. Elna Rudolph and sex in the menopause.
Now, we do have one last comment from Lawrence LeBlanche from SANOFI as well. Just saying, important when thinking about vaccinating the other parent or family members, all individuals do require pertussis boosting every 5 to 10 years. I don't know if it's common boosting just non-pregnant adults, but it's just something to be in mind.
And thank you very much indeed. We look forward greatly. We have to be mindful of the fact we only have an hour's worth of bandwidth. And so I don't want to get into trouble with Karen. We look forward then to the video, which is now going to play on behalf of SANOFI. Thank you, Steve, and thank you, Malikah. Safe home, and
yes.
in all next week. Yeah, same place.
Thank you. Mm.
Overall, vaccination during pregnancy has elicited robust maternal immune responses against all vaccine antigens. It has also resulted in high placental transfer of pertussis antibodies to the infant that persisted well beyond delivery. Vaccination during the second or early third trimesters was considered ideal for antibody quantity and functionality. Studies have been conducted to evaluate the safety of vaccinating pregnant women with Tdap. A randomized trial did not report an increased risk of adverse events among women who received Tdap vaccine during pregnancy or their infants. In another study, Tdap vaccination during pregnancy demonstrated a clinically acceptable safety profile in mothers and their newborns. Follow-up of the same study showed that pertussis antibodies transferred during pregnancy may decrease the risk of pertussis infection in the first months of life but interfere with the infant's ability to produce pertussis antibodies. A similar study established the safety profile of Tdap for the use during pregnancy and asserted that it could be used to provide the children with antibodies against pertussis. However, it reported that children of Tdap vaccinated mothers experienced delayed production of anti-pertussis antibodies for up to 6 months. Such potential reduction in infants' antibody response to vaccines due to interference with maternal antibodies is called the blunting effect. Does this mean that Tdap should not be administered to pregnant women? Since infants are at greatest risk of severe disease and death from pertussis before 3 months of age, any protection that can be provided is critical. Studies assessing maternal Tdap immunization beyond the primary infant immunization series in England and in the United States suggested no evidence of a clinically relevant blunting effect so far. Therefore, the benefits of vaccinating during pregnancy and protecting a newborn outweigh the potential risk of blunting the infant's response. Overall, findings from multiple studies were generally consistent, with similar risks of safety outcomes in vaccinated and unvaccinated pregnancies. It is recommended to receive Tdap during each pregnancy. In terms of safety of such repeated vaccination, no increase in risk was reported despite of recent receipt of a prior tetanus-containing vaccination per a large study from U.S.
So thank you so much, and I do want to thank SANOFI for their account sponsorship, and again, thanks very much to Malikah for the time and effort she made and to make this talk possible. Apologize for the volume issues in the beginning of that video, but thanks again to everybody, and as Pete says, safe home, and see you all next week. Thank you.
Okay.
Thank you. Bye.
Thanks, Fatima.
Bye.